This is your session on physiotherapy for bronchiectasis as part of the Registrar's Training Day in April 2021. My name is Nikki Mills and I'm a clinical specialist physiotherapist for cystic fibrosis and bronchiectasis working at Glenfield Hospital in Leicester. The aims of this session are to review the indications for physiotherapy and bronchiectasis, to think about some of the interventions that we might use when you refer them to us, and a little bit of a review of the evidence and guidelines that we've got to guide our practice. And really what I'd hope you'd achieve from this session is to have a bit of an understanding about when to get a physiotherapy opinion for your patients with bronchiectasis, but also a little bit of an idea about what we might do with them when they come to us, so that you can discuss with patients if they ask you. So you all know all of this. We know that bronchiectasis is a cycle of airway damage, impaired mucociliary clearance, bacterial infection and chronic inflammation. And really, as physiotherapists, we want to get in at that with that airway clearance at the impaired mucociliary clearance phase, because if we can reduce mucus retention and stasis, then potentially we can have a positive impact on bacterial infection and then thus chronic infection and airway damage. These slides were shared with me by Dr. Simon Range, so he may have used these in his presentation as well, but I think they sum up quite nicely how we manage bronchiectasis as a team. So we know that there's that cycle of infection, inflammation and damage on one side of the balance, and then you've got host defences on the other. And what happens in an acute exacerbation is that something tips that balance. So it may be a viral infection or a new pathogen or a comorbidity, maybe different medications or potentially a social factor. And then with antibiotics and some extra physiotherapy and a bit of TLC, hopefully we can redress that balance and get them back on an even keel. However, with some patients, and ultimately bronchiectasis tends to progress, so the infection and inflammation and damage starts to tip the balance in the wrong direction, and potentially we can up the physiotherapy and we can change their antibiotics and we can increase their therapies as a team, but ultimately the balance can be tipping the wrong way and it can be a little bit of a losing battle. So physiotherapy is really important in the management of bronchiectasis, and we actually have fairly decent sections in two national guidelines and European guidelines. So we've got the British Thoracic Society Bronchiectasis Guideline, which came out in 2019, and they talk about the aim of physiotherapy being to minimise distressing symptoms and to optimise physical functioning. And the European Respiratory Society guidelines in 2017 talk about the physiotherapy treatment objectives being to assist in preventing exacerbations, reducing symptoms, improving quality of life and trying to stop disease progression. So that's what we're aiming for with our physiotherapy. As you see as we go through this presentation, there's a big lack of physiotherapy research in bronchiectasis. Evidence for what we do really is significantly lacking, and that made me think about why that is. And I think there's lots of reasons why there's such a poor evidence base for physiotherapy in bronchiectasis. There's certainly a massive lack of funding for non-pharmacological studies. It's quite difficult to get funding for that, particularly in diseases that are lower users of NHS resources. So in comparison to COPD, we really don't use a lot of NHS resources. Powering of studies tricky because of the heterogeneity of bronchiectasis, and also within that there's a big variation in disease severity and comorbidity, so you need big numbers to adequately power the study, and that in the combination of the lack of funding for these studies makes it really difficult. I think the other thing is that our airway clearance techniques that we use with patients are largely individualised, and that makes research methodology challenging. We don't use standardised treatments. We very much individualise our treatments to our presenting patient and their problems and lifestyles, so it does make research methodology very challenging. We need longer studies assessing the impact of interventions on quality of life, disease severity and progression, and again with the lack of funding that can be really tricky. We also need studies in the stable state and the exacerbation, and a lot of studies that the small scale studies that we have got are in stable state bronchiectasis, and that means that we don't know whether that carries over into the exacerbation. The choice of outcome measures is difficult. Ideally, we'd have a longer term study looking at exacerbation frequency, time to first exacerbation, quality of life. If you're doing smaller, shorter studies, the choice of outcome measure is very difficult. There's a big difficulty with blinding because patients know whether they're doing the treatment or not, and sham treatments are really difficult in physiotherapy. There's a problem with ethics of a true control group of no treatment versus treatment, because it's a well-established treatment for bronchiectasis now is airway clearance, so withholding airway clearance is ethically not acceptable. There's definitely a lack of research culture for AHPs, although this is improving. And I think inevitably we cautiously extrapolate the evidence base from cystic fibrosis, where there's a lot more evidence. However, we do need to be very careful with this, because we know in larger studies, for example, of nebulized treatments, the cystic fibrosis lung does not behave in the same way as the bronchiectasis lung, so we do need to be very careful with that. And cystic fibrosis sputum is very different on the whole to bronchiectasis sputum. So what do the guidelines say we should be doing? This is quite a nice summary, I think, of what the guidelines say we should be doing as physiotherapists. So we should be improving patients' knowledge and understanding. We should be mobilising and aiding expectoration of bronchopulmonary secretions, and with that providing some control of cough. So we're trying to minimise coughing. We're aiming to improve efficiency of ventilation through that clearance of secretions. We're aiming to maintain or improve exercise tolerance, reduce breathlessness, reduce thoracic pain, which is really quite common in these chronic respiratory patients, and then potentially to manage continence and musculoskeletal dysfunction as well. So we'll take it in a little bit more detail. We do a lot of education with our patients. We spend a lot of time going through the nitty-gritty of bronchiectasis and the management of bronchiectasis. And really with that, our aim is to facilitate self-management so that patients understand their conditions and can manage it appropriately. So we do go through the basic pathology and etiology of bronchiectasis, how it's been diagnosed, what that means in terms of their symptoms, and we spend quite a lot of time going through infection recognition and management. You'd think patients know when they've got an infection, but they often don't, because they're so symptomatic with their cough and sputum anyway. We'll go through the treatments available and the role of physiotherapy, and really stress the importance of daily effective and optimal airway clearance physiotherapy and how that works, because we need them to buy in to doing this, take the undertaking really of doing their airway clearance on a daily basis. That's really important. So the guidelines tell us that we should be teaching all individuals with bronchiectasis to perform airway clearance, and that should be taught by a respiratory physiotherapist. They say that patients that are admitted with an exacerbation of bronchiectasis should be seen daily by a respiratory physiotherapist until their airway clearance has been optimised. And we definitely do that at Glenfield. We'll spend quite a lot of time with them. It's a good opportunity for us to spend time with patients, making sure their airway clearance is optimised, both whilst they're acutely unwell and then also carrying forward into the home environment. The frequency and duration of airway clearance techniques should be tailored to the individual patient and may be altered during periods of exacerbation. So ordinarily, patients usually do once or twice a day airway clearance in their stable state, but we quite often need to change that during exacerbations, and it may be that we need to change the technique that they're using as well. And the ERS guideline says that patients with chronic productive cough or difficulty to expectorate sputum should be taught an airway clearance technique by a trained respiratory physiotherapist to perform once or twice daily. So what are we aiming for with our airway clearance? We're aiming to have gentle, effective clearance of sputum from the whole lung with minimal cough and effort. And I think there's a few important points in that one sentence. Coughing only clears about the top 1/3 generations of the airways. It doesn't clear what's deeper down. So cough alone is not going to clear those smaller airways. But also we want to minimise that coughing. It's tiring, it can lead to musculoskeletal pain. Actually, it's quite harmful to the airways and can be a cause of the inflammation itself. But also the effort side of coughing a lot means that fatigue can be quite a big problem with these patients. So we want them to be clearing their whole lung, including those smaller airways, but with minimal cough and effort. With that, we want to improve lung recruitment and efficiency of ventilation. And as physiotherapists, we do a really quite detailed assessment so that we can focus our intervention and so that we can individually tailor whichever appropriate technique is right for that patient. There's ways of modifying that technique as well for each individual patient, but also the frequency of their airway clearance and their timing of that. And their timing of that around any inhaled medications that they might take is really important. We'll modify their techniques when there's secondary complications. So if they have quite a lot of bronchoconstriction, are quite wheezy, if they have hemoptysis, if they have pain, we'll modify their techniques accordingly. Another thing that we do quite a lot of is collecting good quality lower respiratory tract sputum samples for microbiology. So there's evidence that physiotherapy generated samples are of a better quality and have less squamous cells in them than spontaneously cough alone produced sputum samples. So we'll spend quite a lot of time trying to get good quality lower respiratory tract samples, and we do things like spend quite a lot of time clearing people's chests and then get a sputum sample towards the end of the session so that we know we're getting that from the smaller airways. This means that we're more likely to get positive microbiology. Self-administered techniques are preferable. Gone are the days where we have relatives percussing people's chests anymore. And I quite like this quote from a paper in 2015, which says the aim is to optimise care, responding intelligently and sensitively to individual and changing patient requirements during their lifetime. So regular reviews and monitoring and altering their physiotherapy techniques as their condition changes and as their presenting symptoms change is essential, really, to ensure optimisation. So we've got lots of different techniques, and how do we select that? Well, what we'd look at to start with is what the barriers to effective airway clearance are. Is it the dilatation and the structural changes to the airway? Have they got much thicker sputum? Is it very stringy? Is it that it's volume that's the problem, and actually it's not the viscosity, it's more about the sheer volume of sputum? Is there mucus plugging? Do they clear plugs, and is there evidence of mucus plugging on the CT scan? Have they got atelectasis or collapse that's affecting airway clearance? Is there a big inflammatory component that potentially needs looking at? Certainly, we spend quite a lot of time ensuring that patients are well hydrated, because if their epithelium is dehydrated, then that's going to affect their cilial beat and effectivity, but also it's potentially going to dehydrate their sputum further, which is going to make it more difficult to clear. If they are tight and wheezy and have an element of bronchoconstriction, then we're going to need to manage that, because clearing sputum through very tight and irritable airways is very difficult. If the patient is fatigued, then that's potentially going to cause a problem. Likewise, if they're in pain. And the other thing that's probably one of our biggest issues is adherence or compliance with treatment, because it only works if you do it. So we've got lots of different techniques, and really we would have a think about all of those barriers to airway clearance that I've just talked about, and have a think about that in relation to that individual presenting patient, and then decide which techniques we're going to use. And these are all physiotherapy techniques which work towards airway clearance, and the ticks and the crosses are whether we've got much evidence specifically in bronchiectasis. So there's really fairly good. I say good, I wouldn't describe it as good, but there's acceptable level of evidence for the active cycle of breathing technique. There's an acceptable level of evidence for oscillating PEP, like the flutter or a cappella. There's some evidence for postural drainage, which I'll come to in a minute, because I would argue that the evidence isn't very strong for that. Autogenic drainage is another technique, breathing technique, that we use that has got some very low quality evidence. It's got good quality evidence in cystic fibrosis, and certainly anecdotally it works very well, but it's got less evidence in non-CF bronchiectasis. And then these other techniques that are used in other diseases have got very little or no evidence to say that they help. So we don't tend to use them as frequently, and the guideline tells us, I'll show you in a minute, but the guideline tells us to use the active cycle of breathing as a first line treatment, oscillating PEP next, and potentially to add in postural drainage. The active cycle of breathing is really quite a simple breathing technique. It's a series of gentle, deep breaths which breaks and mobilizes sputum, and the forced expiratory technique, or huffing, which then moves the sputum up to the upper airways so that they can cough loose sputum from high up in their airways rather than stuck sputum from deeper down in their airways. As I've already said, it just doesn't move, cough doesn't clear it from deeper down. So it's a very simple technique. You can do it anywhere, anyone can do it, and it really is very effective in the majority of people. If they're struggling with that active cycle of breathing technique, then we'd go to an oscillating PEP, and variously the pictures on the right are an a cappella at the top, an aerobica in the middle, and a flutter at the bottom. In UHL, we tend to use a cappellas. There's fairly decent evidence for the a cappella and the flutter. The aerobica in the middle is a new device, and there's some small studies in the aerobica, and there are some studies to show that it causes similar oscillations and positive expiratory pressure to the a cappella and the flutter. And actually, we have used that with some patients and get good results with it, but we tend to err towards the a cappella because it's got a better evidence base. Oscillating PEP is exactly what it sounds like. It's positive expiratory pressure, which helps with ventilating behind secretions and moving them, but that expiratory flow oscillates, so there's a vibration to that, and what that does is cause a turbulent flow that helps to break the mucus, but it also alters sputum rheology. There's some evidence to show that it does actually break down some of the bonds in sputum and thin it out. So these oscillating PEPs are particularly useful in patients with very thick and sticky sputum. There are downsides to it. If you've got a patient with an irritable cough, it tends to make that worse. If patients are prone towards bronchoconstriction, it tends to make that worse. So it certainly isn't a cure-all, and it isn't right for everybody, but for some patients it's very useful. We do use some of these other techniques if we're struggling with the usual, but the active cycle of breathing and oscillating PEP is the main treatment techniques that we would use at the British Thoracic Society guidelines. I'm not going to go through these in detail because you don't need to know it in this much detail. This is what we need to know, but it essentially says what I've just said. The active cycle of there's evidence for the active cycle of breathing techniques. There's evidence for the active cycle of breathing techniques plus postural drainage, which I'll come to in a minute. There's some limited evidence for oscillating PEP, and there's one small study or two small studies, I think, in the VEST that showed that it improved breathlessness and quality of life, but it's certainly not something that we use in the UK routinely. And there's very good study in CF that shows that actually it wasn't as effective as other airway clearance techniques. We haven't got the quality of the studies in bronchiectasis, so we're quite wary based on that CF study. And then there's just some good practice points for us about making sure we're reviewing CT imaging, making sure that we're considering patient preference and adherence, making sure that we're considering gastroesophageal reflux if that's a problem for the patient, and then considering some other techniques if we're not winning. also changing physiotherapy if they've got hemoptysis or other secondary complications. And then we've got the BTS guidelines also give us this stepwise approach to physiotherapy management, which is exactly what I've just said. We should offer active cycle of breathing and consider gravity-assisted positioning and review them within 3 months. In practice, we want to review them within 4 to 6 weeks, really. At that point, if we haven't included positioning, then we'll potentially improve it. But if that's not effective, then we'd escalate to oscillating PEP. And then if we're struggling with that, we'd potentially add in a nebulized mucolytic or mucoactive treatment, and we'll talk about that in a little bit more detail because we've got some more evidence for that as well. The reason I keep mentioning postural drainage is because postural drainage was the mainstay of physiotherapy treatment really until about 10 or 15 years ago, and it involved tipping patients at various angles to use gravity to drain secretions. Now, in the CF world, we don't use that at all anymore, and there's pretty good evidence to show that postural drainage isn't effective. This one study in bronchiectasis is the study that has the recommendations in the British Thoracic Society guidelines have been based on, and it's from 2007, and really it's pretty low quality. They did a one-off treatment, which was either the active cycle of breathing in postural drainage positions, the active cycling breathe in sitting, or the flutter. It was a single treatment crossover study of just 37 patients. Their primary outcome measure was wet weighted sputum, and their secondary outcome measure were SATs, spirometry, Borg, and those other things that are listed there. What they found was that the wet weight of sputum for active cycle with postural drainage was over double that of the active cycle of breathing or flutter. But what they don't tell you, and there's no detail in that study about how they decided on their postural drainage positions. They used 3 positions. What they did if patients had more than one lung affected, how they know if there's bilateral lung disease, that postural drainage was the outcome with that. But what we have got is these other studies. In that study, they didn't radio label sputum and look at where the sputum was actually clearing from. The Sutton paper and the Martins paper and the Lanafors paper that I've listed at the bottom of this page are studies that either looked at postural drainage in a mixed population, which is why it wasn't included in this guideline, or the Lanafors paper was in cystic fibrosis. And these studies all radio labelled sputum so that they could see where it was clearing from, and none of them showed that postural drainage was the effect, that gravity was the effect. And actually what we do a lot of in our centre, and which is common practice in the CF world, is that we don't use gravity to drain secretions anymore, but we do use positioning to improve sputum clearance, because we know that dependent lung regions are preferentially ventilated. And the way that the active cycle of breathing technique works and the way that oscillating PEP techniques work is by improving ventilation behind secretions. So actually we do the opposite. We do use positioning to improve clearance, but we don't posturally drain people. We position in the opposite way, with the affected lobe down, to improve ventilation. And certainly in my 20 years of experience, this is far more effective than postural drainage, which is why I've just mentioned that now. The ERS guideline for the management of adult bronchiectasis is much less prescriptive in terms of the actual techniques themselves, and they ask the question, is regular physiotherapy, airway clearance and/or pulmonary rehab more beneficial than control, no treatment, in the treatment of adult bronchiectasis? And what they showed is that they suggested is that with patients with a chronic productive cough or difficulty expectorating sputum should be taught an airway clearance technique by a respiratory physiotherapist, and that bronchiectasis patients with an impaired exercise capacity should participate in a pulmonary rehab programme. And actually there's much better evidence for pulmonary rehab within bronchiectasis than there is for airway clearance. And really that's the limitation to what they advise. They don't look into the different techniques and give any recommendations based on that. I've already mentioned mucoactive medications, and we use, say, nebulized saline particularly a lot. There's a few studies looking at this. We know that there are a lot of induced sputum studies in general respiratory and in normals, and they show that as you increase the tonicity of nebulized saline, you get an improved mucociliary clearance, and certainly that's our experience. There are some small studies looking at the addition of isotonic, say normal 0.9% saline, and they do show that there's some improved sputum yield and viscosity. But there are other studies that show that using hypertonic saline, say 6 or 7% versus isotonic saline, showed an increased clearance. And until a few years ago, and until the Nicholson study, we used hypertonic saline really quite routinely. And then the Nicholson study came along, and we didn't use isotonic saline at that point very much at all. There was such limited evidence for it. And then we got this study that was over a year, and they used hypertonic saline versus isotonic saline with airway clearance over a year. And what they found that actually they were equal, the isotonic saline and the hypertonic saline both improved quality of life and spirometry, but there was no added benefit to giving hypertonic saline. That's in contrast to other studies that have shown an improvement with hypertonic saline. And certainly, and from the induced sputum data, and certainly in our practice, we tend to use hypertonic saline if we think the patient can tolerate it, and we do see increased clearance with that. But we'll make a decision about which strength of saline we use and whether we use 0.9 or 3 or 6 or 7 based on the patient that we've got in front of us and based on tolerance as well. So we do use nebulized normal saline, and we do use a lot of hypertonic saline, but we would only introduce these when we've optimized physiotherapy and we're still struggling with airway clearance. We really do want to make sure that their physiotherapy airway clearance techniques are optimized before we start adding nebulizer therapy into a patient's burden of care. Just a little bit about other mucoactive medications. Recombinant human DNase or Dornase alpha is something that we use a lot in cystic fibrosis. There's very good evidence for it in cystic fibrosis in terms of short and long-term effects. And we assumed that that would be the same for non-CF bronchiectasis. However, an excellent study in 1998 looked at using DNase in the bronchiectasis population, and actually they found increased exacerbations and a reduced FEV1 compared to placebo over a year. And they nearly had to stop the study because patients were deteriorating on this DNase. And the hypothesis with that is that actually it overthins sputum and makes it more difficult to clear. We need some thickness of sputum, which is why we have mucins there anyway, to be able to clear it and for the cilia to be able to get hold of it and clear it. And actually it probably overthinned it and made it more difficult to clear. Inhaled mannitol likewise has got evidence in cystic fibrosis. However, the studies in bronchiectasis were much less dramatic. They did show an improvement in quality of life, but they didn't show a significant difference in exacerbation frequency or time to first exacerbation, and therefore it didn't get its license in non-CF bronchiectasis. There's very little evidence for oral mucolytics in bronchiectasis, and I think we see a lot of patients coming through, particularly on carbamazepine, but actually until last year there were no studies evaluating the effects of carbamazepine in non-CF bronchiectasis. There's a small study on this bromhexine hydrochloride, which isn't on the formulary in the UK. And there was a very small study in erdostine in addition to chest physiotherapy in the acutely unwell patients, and they showed a very slightly improved FEV1, but it was a very small study and certainly not big enough to recommend its use. With carbocystine, there's this one small study from Macedonia last year. It's very difficult because there's very little detail about the management of the patients alongside that, so the usual medical management, and whether it's the same and comparable to what we use in the UK would be questionable. They said that they showed a reduced exacerbation frequency, but they only looked at that over 3 months. So I think, bearing in mind that a lot of our patients don't exacerbate it in a 3 month cycle, I think, it's difficult to draw any conclusions for this. What I would say is that from our experience, carbocystine is much less useful in bronchiectasis than it is in COPD, likely because of the differing inflammatory process that's going on in the bronchiectatic lung compared to the COPD lung. And what I would also say is that in my experience, if it's going to work, it's quite dramatic. It dramatically thins their sputum and reduces sputum volume. If the patient doesn't think that it's worked, then it probably hasn't. And the guidelines say give a 3 to 6 month trial to see if it's improved symptoms and exacerbation frequency, and if it hasn't, stop it. And we've discussed this as an MDT, and we think that in bronchiectasis it probably helps about 1 in 6, 1 in 8 patients. It's not a lot of patients that it makes a huge amount of difference in. And that's just summing up the BTS guidelines have really just sum up what I've just said. Don't use DNAs. Consider isotonic and hypertonic saline if, in addition to physiotherapy airway clearance, if they're struggling and it's affecting quality of life. Mannitol didn't help, and we can use potential physiotherapies. We can use humidification prior to airway clearance, and we would certainly be humidifying oxygen if they're on supplementary oxygen, because otherwise we're just going to dry their mucosa and make airway clearance more difficult. The ERS guideline says a very similar thing. We don't really know. There's not enough evidence. Do not offer DNAs, but we can offer other mucolytics to patients where it's sputum, difficulty clearing sputum is affecting their quality of life. And again, crucially, where physiotherapy airway clearance techniques have failed or are suboptimal. I want to briefly mention management of the upper airway, because this is a massive problem in bronchiectasis, and it's something that we spend quite a lot of time exploring with patients as physiotherapists. So a systematic review, there was a nice systematic review of studies reporting prevalence or clinical impact of chronic rhinosinusitis in bronchiectasis. And from that review, they identified 8 studies with 797 participants, and what they found is that a mean of 62% had chronic rhinosinusitis, so really a significant proportion of our patients, and that this was associated with a greater degree of bronchiectasis, a lower quality of life, increased inflammatory markers, and reduced time to first exacerbation. So there is a link with worse bronchiectasis and more symptomatic bronchiectasis with chronic rhinosinusitis. Interestingly, it had no association with FEV1, anxiety, or depression. So you do wonder whether they're more fixated or more focused on those symptoms, and the answer is probably not. And it's not associated with FEV1, so it's not necessarily causing a decrease in lung function, but then we know that FEV1 isn't that closely associated with symptoms anyway in bronchiectasis. So what do? Well, we'll assess the patient and try and work out why they're struggling. Normally we'd get them on a nasal spray as a first line, and Avamys would be our nasal spray of choice. We tend to get much better results with Avamys than we do, for example, with Nasonex or Beckinase. In fact, we get very little effect from those. So we'd either start them on an Avamys nasal spray, or if they're on one of the others, then we would switch them to the Avamys. And we would normally give them a good 3-month trial on that. It takes a good 4 to 6 weeks to see much difference when they're on the Avamys, and then usually symptoms improve over the following 6 weeks after that. So we want to give them a good 3-month trial before we decide whether it's been effective or not. And we also go through technique, because often patients are just sniffing it back, and therefore it's not staying in those nasal, in the nose. They're sniffing it back and it's in the lungs before it's had any chance to be effective. If we've given them a decent trial of a nasal spray and they're not improved, or they're a little bit better but it's still suboptimal, or if they've tried a nasal spray and had either pain or bleeding from that, which we do see, then we do teach nasal irrigation. So we use the nose buddy neti pots, which are at the top there, and we teach nasal irrigation. We teach it with saline, so we teach them to make up that saline solution with cooled boiled water, and then we teach them essentially how to wash their nose. So they pour the saline solution at one nostril, and it's very positional, but it should be able to flow and down the other nostril, and then we get them to go back the other way, and we get really good results with this. It sounds awful, but actually the patients like it because it really does clear their sinuses nicely, and the patients that get on with it do report symptomatic benefit from that. But we'll teach them how to do it and we'll talk them through it. I've put saline and bicarbonate there because the jury's still out really whether bicarbonate adds anything. There's a theoretical there's a theory that bicarbonate helps to reduce inflammation, therefore adding bicarbonate helps. And the NeilMed sinus rinse, I should mention that the NeilMed sinus rinse we don't tend to use. It comes in a squeezy bottle that they squeeze up their nose, and what we find is that they don't get very good flow up one nostril and down the other. It tends to go up and come back down again. We find the neti pots much more useful. Now, and the other thing with NeilMed sinus rinses is that they say that you have to use the sachets with it, which means the patients need to keep buying the sachets. And certainly in UHL, the trust won't take responsibility for patients making up their own solution in the NeilMed bottles, but we don't get good flow with the bottles anyway. NeilMed use saline and bicarbonate. What we find when we add bicarbonate is that it makes the water a little bit fizzy, which is really quite uncomfortable when it's going around the nose, and we don't advise that. I've put saline and baby shampoo there because if you Google nasal wash, about the third thing that comes up is a study from Spain where they added a drop of baby shampoo to the solution for washing. I can't imagine how that felt because it must have bubbled up and there must have been suds with that. And their theory with that was that if you could it may reduce bacterial adhesiveness to the mucosa. There's no evidence for that, and I would be worried about using a detergent on the mucosa because we don't want to add chemicals to that mucosa and alter that. So we certainly don't advise that, but we now advise patients not to do it as standard because we had several patients coming back to clinic having tried it because they'd Googled it. I've put sugar as a question mark. There's one ENT surgeon within UHL who advises patients to put sugar in it, and I've never really got to the bottom of why they do this. There's certainly no evidence for it, and I'm not sure that introducing a sugary environment into a nose or that's got chronic infection is the answer, because potentially it's going to feed that infection. So we certainly again deter patients from doing that. And I've put antibiotic there. We've used a nasal antibiotic wash with some of our patients who we're really struggling with recurrent sinus infections, and we've actually had really good results with it. Again, there's no evidence for it, and it is very much a last resort, but we have used it with some of our patients, and we usually use either meropenem or tazocin, and we get them to make that up and wash through with it. And actually, anecdotally, we've got quite good effect, but there's certainly no evidence for that. If they're nebulizing hypertonic saline already, then we may get them to use it via a face mask. This reduces deposition to the lungs, but potentially increases deposition to their nose and may help with clearance. So it's a balancing act depending on where we think we don't want to sacrifice that lung clearance, but it may be that we can give hypertonic saline via a face mask. All of this has got a huge lack of evidence in chronic sinusitis. There's certainly no evidence for these treatments in bronchiectasis and chronic sinusitis, but we do use them with good effect. There is a nasal oscillating PEP called the Cornet, which is the middle picture on the right. I'm not even sure if that's on the market anymore. A rep approached us sort of 5 or 6 years ago for a trial, and we were very sceptical, but actually the patients that we tried it on liked it, but then it sort of went very quiet, and I'm not sure it's on the market anymore, but we have still got some patients that swear by it. And in CF, there's some limited evidence for sinus nebulizers, and this is delivered in a pulsed way to get deposition into certainly the paranasal sinuses, and they've used that in CF to deliver antibiotics and DNAs with quite good effect. So maybe they're the future, but there's certainly no funding already. So the guideline essentially says exactly what I've just said. If they've got symptoms of rhinosinusitis, then trial nasal steroids and irrigation. We tend to go down this nasal steroid and then irrigation route. If they're improved, then we continue with that. And if there's no improvement, refer to ENT specialists. And then there's just a caveat on the right there about alternative diagnoses and just being careful that we're not missing anything. I was a little bit surprised that they've got crusting there, because crusting normally really improves when you use a nasal wash with patients. But there's BTS guidelines for that. And as physiotherapists, we can assess all of this and advise about their management. Just very quickly, if they've got atelectasis or lung collapse, then we're going to address that as well. And really, we want to get in there early with that. We want to clear mucus plugs. We want to re-recruit collapsed lung. So we're going to do our usual airway clearance techniques with that. But we're potentially going to use positive pressure as well. So we might use intermittent positive pressure breathing, or the bird. We potentially use PEP. We may use the bird with a PEP on the PEEP valve on the expiratory port, so that you're getting inspiratory and expiratory positive pressure. We usually really push exercise with these patients, and we will combine these treatments. There's a big lack of evidence in this. It's really just feeling it as we go and throwing everything at the patient to try and clear those plugs and get that lung reinflated. And this is a patient of ours that used to come in regularly, hasn't actually touched wood recently, with complete collapse of her left lung because of mucus plugging. And really our aim when she used to come in was to use physiotherapy to clear that and to re-recruit, rather than for her to have bronchoscopies. Apologies for that phone call. I'm on call tonight, so that was the hospital trying to get me to come into a patient. So just very briefly about exercise, there's much more evidence actually for pulmonary rehab than there is for airway clearance, and again it's a little bit easier to assess, and the precedent is there because of COPD. But there's a really nice study that came out last year, and that did show that less active or more sedentary patients with bronchiectasis are 6 times more likely to be hospitalised. So we know that exercise and regular activity is really important. We should be promoting an active lifestyle, confidence to exercise. That should be sustained long term, and it should be an individualized program including cardiovascular and strength exercise. And then there's various studies evaluating pulmonary rehab in bronchiectasis, which have shown an improvement in exercise tolerance and improvement in quality of life with various measures. But actually that, again, like COPD and other chronic respiratory conditions, it's not sustained at 6 or 12 months. So getting them to sustain that exercise and continue it is the biggest challenge. There was also that study that I've put in from 2011, the ONG study, that looked at bronchiectasis versus matched COPD patients, and they showed that they got the same improvements. So in theory, we can cautiously extrapolate that huge body of COPD data to bronchiectasis as well. This is just saying that really as well, we have got systematic reviews, we have got other studies, and we've got the studies looking at adding in the a cappella as well, and all of them show the same thing, is with that they get an immediate improvement, but they're not always sustained. The one study that did get sustained improvement was that Newell study, and their patients got a free gym membership at the end of the study, and ongoing support within that gym environment, so they weren't just left to go it alone, and they did show some improvement in some sustained exercise endurance at 3 months. So the BTS basically says we've got evidence to show that pulmonary rehab does help in terms of exercise capacity and quality of life, and that we should offer pulmonary rehab to all individuals who are functionally limited by shortness of breath, and we certainly have a very low threshold for that. They have got this level B evidence to consider the use of inspiratory muscle training in conjunction with conventional pulmonary rehab. There was one study that showed a slight superiority in patients that had inspiratory muscle training as an addition to pulmonary rehab, but that's certainly not something that we do routinely, but it may be something we consider for patients that aren't getting such a good outcome with pulmonary rehab. So essentially have a fairly low threshold for referring to pulmonary rehab. We'll manage breathlessness. There's very little evidence of this in bronchiectasis. There's a little bit of limited evidence in COPD, which I've added there, but we'll use all of our usual physiotherapy techniques. So again, lots of education and advice and reassurance about how to manage their breathlessness. We'll teach positions to manage their breathlessness and go through relaxed breathing techniques. And again, we'll refer to pulmonary rehab to make sure that they are optimizing their exercise capacity. I just wanted to mention dysfunctional breathing, because people see dysfunctional breathing patterns and breathing pattern disorders as a separate entity, but actually it's really common in our chronic respiratory patients, and it's common in bronchiectasis. There's no research studies on this, but we did a review of our clinic population a couple of years ago, and we actually found that 1 in 4 patients with bronchiectasis that present with difficult to manage symptoms were dysfunctionally breathing, and actually that accounted for quite a lot of their difficult symptoms. And actually when we normalise their breathing pattern, it can significantly improve symptoms. So our aim of treatment with that is to normalise their breathing pattern, to re-educate their breathing back through their nose, and to do our usual breathing pattern correction. We get really good treatment success rates with that as well, and it can significantly improve their respiratory symptoms despite the background of bronchiectasis. So if you've got someone that's got disproportionate breathlessness, or an irritable dry cough is often a sign of dysfunctional breathing as well, and a lot of bronchiectasis patients will present with a mixed cough picture where they've got productive cough and a dry cough. Consider dysfunctional breathing, and if you're not sure, ask us to have a look, and we'll give an opinion. I've mentioned cough, but we do see patients with this mixed cough problem, and often the dry component of their cough is more troublesome to them than their productive cough. So obviously we want to optimise airway clearance so that we're reducing productive coughing, but we also want to reduce that dry cough, and often they end up with an irritable dry cough because of overcoughing and sometimes a breathing pattern disorder. And we want to reduce that dry coughing, because if we can stop them coughing, then their mucous membranes in their upper airways will be much less irritable, and they'll have less urge to cough. So we'll go through cough control techniques and behaviour change to try and improve that dry coughing. And I've just added this study on. There is some evidence that patients got improved cough and improved cough quality of life scores with the Leicester Cough Questionnaire, with breathing pattern correction and cough management. So certainly we'll do that. And if you've got a patient that you feel is coughing excessively, do ask us for an opinion. We do all the other usual stuff as well. So we'll optimise oxygen delivery and humidification, we'll assess for ambulatory oxygen and titrate that, and we'll get involved in NIV for respiratory. And just for completeness, I've added in the BTS guidelines advice on that. What I would say to you is that non-invasive ventilation in bronchiectasis is much more difficult than it is in COPD in terms of tolerance sometimes, and often that's because it mobilises secretions. Those increased tidal volumes mobilise secretions, and actually we get much better success rates if they have quite early physiotherapy and intervention for the airway clearance alongside commencing non-invasive ventilation. And often we don't leave them on it for that first 24 hours as much as possible like we would in COPD. We need to take them off regularly to be able to clear the sputum that it's mobilising so that they can then tolerate the NIV. So do get physiotherapy involved if they're struggling with the NIV. Really, that's it. And normally I'd ask if there's any questions. I will come into your live session just to see if you've got any questions, but that's just an overview of what we do. And please do refer for physiotherapy if you have opinions if you're not sure, because if you're not sure if we can help, we'll just tell you yes or no. We're more than happy to be involved and to assess them and to say yes, that we need to do this, or actually no, we didn't. Thank you.